One thing I'd like to ask, certainly Sharon and Trevor, NHS Scotland have guidance on loan sets. It is slightly out of date, but if we're talking about reviewing our guidance, it's not so much an SHTM, it's like a guidance note to run in parallel. Do you think we, you know, England, Scotland, Ireland and Wales should possibly utilise that guidance document, upgrade as part of the future guidance revision? And do you think it would certainly help with the problems you've highlighted, Sharon?
I'll leave that to you. Mr. Garcia.
Thank you. So, yeah, I think there is. So if some of you who were around in about 2010, there was some combined ABHI, AFPP and IDSC guidance that came out for loan kit. I've been working with AFPP recently. We've got it in near final draft, or in final draft. Should be going to the two relevant boards, the AFPP and our board, for approval, and then that would be issued. So that is ensuring that we are looking at from both a theatre practitioner's point of view and getting their input, and also from obviously the decontamination viewpoint as well. So we're looking at, and also it includes procurement as well. Mm-hmm. So it's looking at procurement, theatre and decontamination. I'll be honest, I haven't read the Scottish one, but that was because we had already had that the document. We've just thought it'd be a good idea to update, refresh.
Do you think we should put that governmental stamp on it, though, as we've
done? I wouldn't. I think yes. There's absolutely no reason why not. It seems very sensible to me. I think we need to get it. We should be able to get it agreed, hopefully in the next 2 or 3 months. And then, yeah, I think there's absolutely no reason why it shouldn't go through the relevant.
Any thoughts on that, Sharon?
I just like getting on my soapbox, John. I do. But yeah, I mean, we are working, as Trevor said, and it's just about getting everybody else on board. We've tried to reach out to Girth as well, haven't we?
Yeah.
Get it right first time, because that's looking at the theatre side and how to better implement their lean processes in with decontamination. But you tend to find you get with these, you know, affiliations, and then somebody leaves and then somebody comes in and it's starting all over again. It's like, I don't know, it's like working for the Nuffield, and every time they change an hospital director, you have to restart the whole programme. But I just thought it would be really good if we can get as much information in, and then it's a wide spectrum, and then we collate that information, then send them out to these manufacturers.
Just a question about collaboration between trusts, I would say. We come from Barnsley, head of service for Deacon and MedEng, and again, same issue. So thank you, Sharon, for that presentation. I think it was very relevant to what we're also experiencing in Barnsley. And the question is specific on decontaminated trays from your own unit. South Yorkshire is taking over by Supercentre, which I guess Birmingham is also that scenario. Is that a way to think, to operate within trust where we can speed up the process? Because £500 a day is a lot of money, and we've got decontamination services with experienced technicians that could kind of support other trusts.
I think the only pushback that I'm doing within UHB, and I've got all the general managers are on board because they need to make a saving, is to go back and ask, why are we having that loan tray in? You know, and I'm pretty lucky. A couple of the surgeons, they don't want to decapitate me, but the couple of them will work with me. But it's asking that question. You know, if there's a clinical need, or, you know, a patient's come in with a totally different implant and we don't hold stock of that particular tray to remove that, but they've got to understand the cost implication. And when you've got an off-site service, you know, if we could just work with the manufacturer and say, let's have it in a sterilisation container, then that takes some issues out. It's just engaging with them, but I tend to go back through procurement.
Hi, my name is Simon. I work at Trafford Hospital in Sterile Services Department, but we're more of a recipient distribution unit. We use Sterilizers within for processing and equipment. And we have seen a significant amount of lung kit going through the hospital, especially in the last couple of years. You can clearly tell the difference without even running numbers. A busy week used to be maybe 3 or 4 lung kits a week. Now you can see 5, 6 a day, sometimes on the worst days. Now, it is an elective hub, so there is an idea why we would have more complex cases sometimes coming through the door that you do not wish to interrupt for any reason. But from time to time, our team who lead efforts on the lung kits did try to challenge some of the ideas of bringing some of the kits that are needed for a specific kind of surgery, say, for example, a knee surgery, and ask a question, why is it we have to bring the kit from this particular company and we cannot use the one that is already on the shelf? Now, when you bring that question to the surgeon, who is of course qualified and the best person to answer that question, but is also the person of interest who wish to use that kit, you begin to wonder, is it still necessity or is it preference? Is there a gain for it for patients themselves? And is it significant enough to spend the money? The statistics that you brought on the screen show a clear picture of just how much costs is associated to the lung kits, and it's massive. So my question is, do you have a system in which you are able to challenge some of these lung kit requests? And if you do, when you do challenge them, do you have perhaps someone you can rely on that can objectively advise on the subject to you? Or is there perhaps another model that can be followed to more efficiently draw the line between preference and necessity?
Yeah. At UHB, we have clinical lead specialists. So they are the overall arching surgeon. So what we tend to do is obviously not do it in the foreground, but we'll get the information and then go back, because those clinical lead specialists are obviously there for ensuring patient care, but they've also got a duty with regards to the budget. So we tend, in UHB, we tend to go through the CSR, so they are my main people that I will report back to and just show them the trend and let them make their information, because at the end of the day, they are then next responsible to the medical director. And then they've got to justify why they're an overspend. And then it's just working with them to say, you know, it isn't always sterile services' fault when there's a torn drape. But if it arrived on a Wednesday night and they want to use it Thursday morning and everybody's rushing around, the risk is there unless we go back to the basic and then, you know, educate them to say we need sterilisation containers, or we need a better container that's going to be, you know, at less risk of damaged drapes. But I think as an NHS, we all work differently, don't we? I mean, we used to have one chief executive and 4 sites. Now we've gone back to clinical decision groups. So I've got to start all over again. And the clinical lead specialists, they only tend to do 2 years. And you just get in there and then somebody else comes in. And then they've got a different priority.
I think for me, touching on that, you mentioned, you know, we're using certain trays more frequently. Would it make, and excuse me, it's not really my speciality, but would it make sense to perhaps, you imagine a number of trusts is something we could do in Wales, the South Wales Basin, as a matter of fact. Could we own a set and perhaps share the asset? Yep. Is that an option?
Yep.
As in share across the hospitals?
Yeah, share across a number of trusts.
That's one of the things that, one of the benefits of a big centralisation, just one of the benefits, is what we can do, because we use third party, we can track and you know, get that information and then see that, but we're a couple of years away from that. But it would be nice to, you know, if that tray is regularly used, then use it as at the hub, and then when it's needed, it's a bit like a Waitrose order, and then it goes out.
We do share occasionally equipment between Manchester Foundation Trust hospitals. We often lend each other between Trafford General and Wythenshawe Hospital, particularly between us and A Block theatres. We do also, I would say, second most we rely on will be the MRI, especially the phase 2 theatres located over there. And then furthermore, we also exchange, occasionally help each other out with the private sector, such as, come to mind. must say there's about 3, maybe 4 different ones, but they are quite rare, I'd say. And we do try to make a point of also processing through our units before them being used, of course. We do run a clear record of what arrives on each day, because with the quantities that we do, it's really easy to lose track. And within the past 3 years or so, I would say we have about over 2,000 entries on that record. That is 4,000 transfers, one back and forth. It's becoming actually a quite significant workload for our team, because we are right at the back of the hospital with the loading bay. All of it comes through our hands. And then there comes also the risk of when they are wrapped, damage wraps during the transportation, so we sometimes go above and beyond to bubble wrap it even, keep some aside for that kind of occasion. We do have a lot more trays in tins now, which simplifies the process, but it's the little things. Sometimes we approach even a courier or a taxi or whoever does the favor of transporting it, and we even urge them when they grab in the Skilab containers, and we say, please don't grab by the edges because you're gonna snap the tamper lock off, because sometimes they don't even realize what they're handling. So it's all these little intricacies that get the tray from one end to another and actually get the case done. Because one snap of the tamper lock or one hole in the wraps and everything can go out the window. And then do you have the time to transport another? So yeah, there is quite a bit of that between us, but there's also quite a few kits that are rare. Among others, we have a revision kit from the Puisin fees, and as far as I can tell, if anything goes wrong with ours, there's nobody nearby that we can rely on. That's where the reps often come in to help. Then furthermore, I would say, yes, there's few other kits, and sometimes even when you have this kit on the shelf and you got 2 sets of trays, sometimes you get a need of 3 surgeries on the same day, so you bring a loan kit that is an equivalent of this what you already have shown on the shelf, so you have the consignment kit and you have the loan kit. So it's
an industry in its own, isn't it, loan kit? I know there's a Royal Orthopaedic Hospital in Birmingham, and they've got a team of 7. No sterile services, that's just a team of 7 to deal with what comes in and what goes out.
Do you think that area, we talked about training this morning, but probably we go to a lot of effort and time within the SSD, and then it gets to the clinical environment. We've talked about, rips in surgical sets. We've talked about misuse. Do we think training at point of use is a big issue, and how do we overcome that? We're looking for the SSD perspective, but probably that's a bit of an underlying area.
Yeah. I mean, I know that most orthopaedic complex tray always comes with the rep that's in theatres. So they end up taking over, and they go, yeah, use that, yeah. And the scrub nurses are nil and void. They're not even handling the stuff. And there's 15 trays, and they use one device out of each one. But I think my problem is, and my gripe is with the representatives, if there is a cancelled case and it's because of the containment or they weren't showed out to disassembly, they never go back to their regulatory bodies and go, oh, by the way, a cancelled case, they didn't use a trade because that happened in theatres. And that's what I want to change with them, because I'm fed up of hearing, well, Sharon, they use this at Sandwell City and they don't have a problem. I'm really, let me ring them up. I'll soon find out if they've got a problem. And then they go, oh. So I just cut them out. The representatives are there to look nice and show off the kit. I go to the regulatory body and say, you've caused a problem.
We have improved since then. Thankfully, a lot of kids that are introduced into our hospital go through our department, so we are very proactive at looking at the containers they come with, whether it's long kit or consignment, and we pinpoint and say that's going to be a problem, that's going to be a problem, that's going to be a problem. And we say if whoever's handled the tray is going to treat it like a baby, then you're not going to have a problem, but you need to be a bit more realistic and say we need a bit of a wiggle room when you have a design of the tray that say that slightest skid on the surface is not going to tear the wraps. Just the other day, we had a prep board tray arriving from Afrex company that was, I checked personally, it was 7 kilo in total weight. The container alone was 4. It had 5 instruments inside. It was also about 30 or 35 centimeter tall, but that was because the company insisted on the instruments being kept upwards instead of flat on a base. I saw the rep unpacking the whole things that Trust just purchased, and I straightforward asked him, can we get a refund for the containers? I'm going to put this on the bin baskets, I'm sorry. So it's, we're trying to be proactive, but it's good when you have that in mind for future problems when the kit comes through your hands. And I know that some of the DSD departments might not have that power like we do to challenge it on the spot and say, no, that's not going to work for us, or that's not going to work with our supplier. We need to change that, or we will have a problem time and time again.
I think because 9 times out of 10 the SSDs are firefighting, aren't they? So I know I certainly was, you know, when I used to run an SSD, it was like, just get it done, get it, whatever you do, get it out, and then you know, you're on to the next problem. So if we can collectively get as much information and then present it, that there is an issue, we need to get it sorted, then hopefully we can get people on board.
Richard, Trevor, anything to add?
Going back to your original comment, I think John was around training. So yes, when I ran an SSD, when the companies that supplied the trade reps, etc., they used to come in and train our staff, and then they had to go into theatre and train theatre staff. That was part of the agreement we had with them. And the people who come from that company were ex-theatre staff. So the representatives were ex-theatre staff, so therefore I felt that hopefully they would be more acceptable in what they said, because they were ex-colleagues, if you like. Nah. I lived in hope and I failed. There was still, she came back, I couldn't possibly say what she said, but she was very disappointed in the reaction and that it was still, everything was SSDs full. Despite the fact she'd been going to them, you do not stack 5 sets on top of each other, you do not stick them on the sides, you do not ram them onto shelves, you don't put 11 kilogram trays up on the top and then drag them off. It was, yeah, disappointing. Maybe it was just my trust.
No, I don't think so. Richard?
Yeah, when I used to run a SSD department, yeah, loan trace, I do appreciate our colleagues saying there what are the realities or the situations that we have. Most of the time it's consultant-based decisions that we have to encounter in SSD. So what we did is a multidisciplinary approach on that, where it involves justification of the loan kits, reviewing the operations that every consultant does, what loan kits will be involved, and then what will be involved in every day, and the timeline of when to receive it and who's responsible of checking it. So during my time, I always have a loan day Thursday, which is talking about loan trace in the second week time. And we will receive the loan trace a week before. So it will not, the processing of it will not hinder the staff well-being or the process of the department. So we will not rush up, there's no fast track, because everything, well, on my case, everything is elective. At the end of the day, I already know that it's happening months ago. So why not sort it in? The problem is from the suppliers, because these are moving around. But once you had that conversation and an agreement, and that's where I come to the point where written terms of agreement is valuable, where we understand the KPI of it, or do they meet on that? Otherwise, we will look and say bye-bye to them and have a look, discuss with the consultation. And remember, every consultations are trained to use medical devices in a wide span of options. One there is total knee replacements, so they can use different approaches. I do understand when their request is for a certain approach depending on the patient's findings, but to have a request just in case, like a separate set, then no, because that's one is a cost, waste of resources, and then you did ask about how to justify that, is that you go back to your traceability reports and everything and discuss, oh, you borrowed just in case sets and we've never used them. So what's the point now? So gaining those understanding those numbers, and that's where your digitalization or any form of track and traceability comes into place. How to use it and take that advantage of using that, because it will give you numbers that don't actually lie if the system is managed properly. And that's the most important bit there, if it is managed properly. And the understanding as a multidisciplinary approach, if the theaters are willing to engage with you and to be a part of you, then you can discuss those things. And especially with the consultants as well. So, and for me, I'm lucky to have consultants who are very engaging to us. Can we discuss what I need? Because before they are contracted to the organization, they actually tell you what services they will be able to provide. And then you can start a discussion from the terms of them being contracted to, and use the multidisciplinary approach to discuss what they need. So there's no surprise decisions that they want. You can accept once or twice in a month or 3 times, but not every single time. I think it's a multidisciplinary approach that would help us. And obviously the timeline of processing it. And then who's taking responsibility of checking them. For in my case, it will always be theaters. It will always be theaters. And not my, because they will be using they will be the rep. I always instruct the rep to discuss it with the clinicians or to the staff nurses, and not through SSD. Because our main role is to process what they want. We don't decide if their set is complete. They have to decide that is this enough for what you need it to. And I think that's where it is.